Thank you very much for the great opportunity. I also thank our respected chairpersons and also our GVK Anna for giving me the great opportunity. Dear friends, why this topic is very important? Diabetes and elderly. Usually in our clinical practice, we used to see a lot of elderly patients. Among the elderly patients, they have a lot of comorbidities with a polypharmacy. So with these comorbidities, they are mainly predominant for the hypoglycemia and other complications. So they require some sort of extraordinary care and support, not only for the patient and the team that was convincing with the elderly population, including the family members. So this is a female. This is a lady behind this geriatric unit. She is Mary Warren. She's a boutique surgeon, and she fought hard to create this geriatric clinic in London. And she understood that all the doctors should know how to treat the elderly population, because elderly population with diabetes, they need a special care and attention to prevent the complications. And she has been considered as the mother of modern geriatric medicine. This is my roadmap: burden of diabetes in the elderly population. Why is it important to consider the elderly as a separate group in type 2 diabetes? What are the challenges in the management of diabetes in the elderly population, and the pharmacological approach of diabetes in the elderly population? So, it is so fascinating. These are the data given by Banerjee, that if you see in India, with the evolution of modern medications and the innovation technology, there is rise in the longevity. If you see the data from 1961, the life expectancy was 42 years. And 2018 was 69. In 2050, it may jump to 76 years. It's very, very interesting also. The life expectancy at 60 and 80 was increased significantly, now standing at 18 and 7 years, respectively, and projected to be 21 and 8.5 years to 2050. So, it's so happy to see that Indian elderly population is growing by 3 times on comparing with the other Caucasian populations. This is the burden of diabetes across the globe. If you see the prevalence of diabetes among the elderly population, it was 136 million, and it may jump to 195 million. The sad part of the story is, almost from this chunk of the population, 50% of the elderly population having the type 2 diabetes over the age of 65. So globally, they have listed around 5 countries. Among the 5 countries, India stands 3. So almost 11.0 million population, that is 17% of the older subjects, the age more than 65, are suffering from the type 2 diabetes. Very, very alarming also, and therefore we have to give the special care and attention in our clinical practice to prevent the complication. This interesting data from National Sample Survey, what they alluded, Banerjee clearly alluded that they did the survey on the rural area as well as the urban area. They categorized the 3 compartments. One is younger old, old, and oldest to old, and they are being called as the octogenarians. If you see the prevalence of diabetes among the elder population in this age subject, they were somewhere around 31 to 35%, but in overall they are able to see around 28%. This is very, very alarming also. So, why it is important to consider the elderly as a separate group in the type 2 diabetes patient? So, aging contributes to the pathogenesis of type 2 diabetes both directly, though decrease the beta cell function, which reduces insulin resistance and insulin secretion, and though obesity and other risk factors have been included. If you say the cardinal risk factors with aging and obesity, it is bidirectional. Aging contributes for the sarcopenia, skeletal muscle dysfunction, so on and so forth, including the obesity contributes for the insulin resistance, central obesity, ectopic adiposity, vascular inflammation, so on and so forth. This will compile, and they give up for the decrease the insulin secretion and increase the insulin resistance, which contribute for the uncontrolled hyperglycemia and paving for the way for both macrovascular as well as the microvascular complications. If you see the common clinical conditions associated with the aging, almost 60% of the older population with the type 2 diabetes have one comorbid condition, that is having the cognitive decline is very important among the elderly population. Polypharmacy, disability, depression is very, very important, because if any patient, if you see elderly population more than 75 or 80, almost most of the elderly population may have some depression, either in the impact of disease or in the impact of the family. 40% of these patients have the minimal for concurrent illnesses, including urine incontinence, fecal incontinence, falls and fractures due to sarcopenia and cardiovascular burden. The clinical presentation diagnosis is somewhat unique also with this patient. See, the 2 hours plasma glucose with the OGTT are more reliable than the fasting sugar. And the clinical presentation was somewhat varying. There doesn't have any asthmatic symptom. Therefore, we will miss the patient doesn't have any asthmatic symptoms. And the assessment also should be studied in the proper manner, doing the vascular disease, physical and neurotropic functions, as well as the mental and cognitive functions very important among the elderly populations. These are the reciprocal relationship between the mental dysfunction and the physical neuropathy compilation. Professor Sinclair Allen clearly alluded the importance of this combination as a bidirectional, and therefore mental dysfunction accompanying with the dementia, depression, and physical neuropathy complications, sarcopenia, frailty will contribute for the vascular impact both on macrovascular, microvascular complication, which is lead to the disability of including visual loss, mobility, falls, and also increase the morbidity and mortality. What are the challenges that we face in the management of diabetes in the elderly populations? So these are the challenges. We know about geriatric syndromes, that is delirium or cognitive impairment or decline, frailty and decreased mobility, depression. Depression may be due to the loss of the partner, female partner and male partner going for depression. So there is a looking solemnly and alone in the family also, and some sort of food problems. So these are the areas they will go for other consequences because they will not take a regular meal, and the refusing glucose monitoring, refusing medication of injections, and the required assistance with feeding, and also falls we have. And these should be subjected, and we have to give the counsel accordingly, because simplified medication regimen is very, very important. De-intensification of treatment also is important. Nutrition consultation and psychosocial counsel is very important. Access and grade and treat the depression also is very important. Euclipides multiple times they have hypotheticated the importance of tight glycemic control. They saw the benefit of microscope complications, but later on they see on the macroscope also, but not with ACAT. But in the elderly population with the old or frail patients, this is not possible because they are predominant for the hypoglycemia or hypoglycemic unawareness. Elderly population, the single hypoglycemia, they land up in cardiac autonomic neuropathy. That is one of the main menaces among the elderly population. They land up in atrial fibrillation, ventricular flutter, that we have to keep in mind. So tight glycemic control, it should be always tailored for the elderly population to prevent the complication, including hypoglycemia and also cardiovascular burden, including the morbidity and mortality. Sarcopenia is important, challenging burden upcoming across the globe, and also important to us to realize among the diabetic patient also. Any subject age crossing more than 55, they are predominant for the sarcopenia, that is muscle loss, muscle strength, or muscle function. Every year after 55, there will be muscle loss by 1.5 to 3.5%. That will contribute more by the aging population, that is diabetic population with poor glycemic control, mitochondrial dysfunction, oxidative stress, and so on and so forth. So treatment goal is to culminate over the controlling the hyperglycemia that is associated to control the sarcopenia also. That is because any drug you give, that should not be interfered with the sarcopenia, and therefore the other sophisticated medication can be considered included in the DPO inhibitors or GLP drugs like that. De-intensification is very important, my dear friends, for the elderly populations, because where we want to impact this de-intensification, because any drugs that patient doesn't need for the longer treatment does not improve the quality of life. That is because statins after 80, it won't be any effective. So we can reduce that sort of unwanted molecule, and also we can reduce some sort of unwanted molecular protein supplementations like in oral form or any form of this one, multivitamin like that. So where we have to consider the de-intensification, short life expectancy, low cognitive function, and so on and so forth. So approaches for de-intensification include the de-prescription of antibiotics, switching over to other drugs, de-prescribing medications, and also reducing the diabetes-specific assessment. Another important area is post-menopausal women, because post-menopausal women with diabetes, they are predominant for the inflammation, including the visceral adiposity, adiposopathy, and cytokine surge with endothelial dysfunction, which is contributing for both cardiovascular burden as well as this one stroke burden. And it is contributed more by depression as well as the vasomotor functions, sleep disturbances. And therefore, in these patients, apart from the control of hyperglycemia, they need the appropriate lifestyle modification, and also the management of BP, lipid management, and antiplatelet therapy also should be considered. Inpatient management among the elderly population is very, very important because they are more predominant for the inpatient admission by means of hypoglycemia and hyperglycemia. Intensifying the glycemic control, overuse of insulin therapy, insufficient of patient education may go for hypoglycemia, and therefore tailor-made approach, patient-centric approach is very important among the elderly population to prevent the complication. DPO inhibitor with the low dose of metformin also very applicable for the elderly population to prevent the complications. What are the pharmacological approach for diabetes in the elderly population? Is our area is very, very important idea because we want to practice lot of patients in the elderly population. So all the global consensus, ADA, AAC, American Geriatric Association, they have maintained the two columns. One, the patient, the healthy means you can maintain the HbA1c between 7 and 7.5, but if the patient old, frailty, they couldn't be able to have the independent support means just somewhat you relax the HbA1c between 7.5 to 9, so that's very, very important to prevent the complications. Management targets and goals therapy. So they are categorized into independent patients, those who are able to do the work properly, partially dependent and dependent. So these are the things to be considered: management pattern, proper nutrition, appropriate exercises, adequate protein intake, and appropriate protocols of treatment, and insulin adjustage, insulin initiation, titration, and intensification are very, very important targets and goals also to prevent the complication, to prevent the hypoglycemia. This one, mental support, psychosocial support, and extra care should be given for the elderly population to prevent the complications. ADA keep on insisting to prevent the hypoglycemia. Medications are with the low risk of hypoglycemia are preferred. Over-treatment of diabetes should be avoided. De-intensification of the prescription is very, very mandatory, and also consider about the cost also is very important. This is a snapshot of the current option in glycemic control. Avoid issues like glycemic and gluburide, and insulin level should be titrated properly. Long-acting basal insulin should be considered, but the titration is very important. The morning type basal insulin will be efficient for the elderly populations. Regarding with the insulin regimen, simplify the insulin regimen is very important. So you have a patient on basal bolus, so switch over the bolus in the morning time, and also mealtime insulin can be reduced. If the patient already on more than 10 units, you can reduce by 50%. If the patient is less than 10 units, means you can stop the insulin and go for non-insulin, medications is very important. Metformin, even though it's the first kid in the block, but it has a lot of challenges over there. Metformin per se itself will have vitamin B deficiency, GI intolerance, and so on and so forth, but does not have hypoglycemia. But there are some challenges over the kidney burden also if EGFR less than 45. Even though metformin is the number one drug, but it has a lot of controversies: respiratory failure, hepatic failure, cardiac failure. That are a lot of contraindication. Even with the patient with bronchiectasis and respiratory hypoxia, this metformin is contraindicated. Once again, new kid on the block, SGL inhibitors, we are more fond of giving this more and more, but consider genetic myocardial infarction, then EGFR less than 45. Keep alarming. EGFR less than 30 is not indicated. But in patients with cardiovascular heart failure, these molecules may be helpful, but tailor-made therapy is ultimate, very, very important. SUs, good drug, good molecule, but cause hypoglycemia, weight gain, and therefore hypoglycemia prevention is also very important to prevent. And with the glitazones, once again we know that it doesn't cause hypoglycemia, but it has the impact and burden of the risk of fractures among the female populations, those who are post-menopause osteoporosis, and CKD, once again alarming, and CVD, once again alarming, for provoking for the cardiac failure. So DPO inhibitor, wonderful molecule. This preserves the muscle mass. DPO inhibitor doesn't have any impact on the muscle mass, and therefore this is a good drug. Low dose of this one, Sita, Lena will be helpful because these are the proven molecule with the TICOS trial and the Carmelite trial, and that can be given. But the only thing is we want to give the molecule proven to CVOT to prevent the heart failure. But any patient with increase in NT-proNP, but this molecule should be avoided because all the gliptins have the impact and burden of the heart failure with reduced ejection fraction less than 45. So a physician once said, the best medicine for the humans is love. Dear friends, we have a lot of elderly patients. We have our own parents with age more than 70 with multiple comorbidities. So appropriate diabetic care to prevent the hypoglycemia, and ultimately the touch with the love and extra love is important. Someone asked, what if it doesn't work? He simplified and said, give the extra dose of love. So giving extra dose of love to the elderly population is very important for our patients also. So Lord, help me to remember I am doing your work. Thank you for the great opportunity.